Welcome, one and all. My name is Dov Fox. I teach at the University of San Diego's Law School, where I direct its Center for Health Law Policy and Bioethics, one of the co-sponsors for today's debate, which is hosted by USD's Center for Ethics, Economics, and Public Policy, run by political philosopher Matt Zwolinski, who organized these proceedings on a topic that could hardly be more timely or pressing as the pandemic continues to rage and to inspire limitations on what we can do, where we can go, and who we can be with. As states worldwide have instituted a variety of measures to reduce the spread of a potentially deadly virus, these restrictions themselves impose collateral damages to everything from employment to education to mental health. To help us think through these complicated policy trade-offs and how they should inform our decisions, we're joined today by two supremely qualified guests. Making the case that the pandemic poses one of the strongest cases for government intervention, we have Jeremy Horpedahl, a professor of economics at the University of Central Arkansas and a prolific scholar at the state's Center for Research in Economics. Arguing that many of our public health policies have gone too far is Phil Magness, an economist with the American Institute for Economic Research. He's author of 5 books and scores of articles on economic history and inequality. Each of our speakers will have 15 minutes for his opening remarks and about 7 minutes for a response, after which we will open the floor for moderated discussion. Please submit your questions at any time in the Zoom webinar platform. You can see them in that Q&A button at the bottom right of your screen. And I will put your questions to the speaker during the Q&A portion of our event today. With that, a hearty welcome to one and all. And I'll turn it over to our first speaker, Jeremy Horpedahl.
Thank you, Dov. And thanks, Matt, for the invitation. And especially thanks to Phil, my friend, who we have disagreed and discussed this issue many times over the past year, and I look forward to this discussion. Phil and I disagree a lot, but I always learn things from talking with him. So I hope that we can learn more tonight. Especially hope all of us who have joined, all of you who have joined us, can learn from our discussion as well. And I really look forward to the questions too. We were talking before we got online here that I just got my second dose of the vaccine for COVID yesterday. So I feel very fortunate. Arkansas put educators near the front of the line, and I got in line as soon as they let me, and I just got my second dose yesterday. So very excited about that. I think back to when the positive results of the trials were first announced for the Pfizer vaccine. That was on November 9th. That's exactly 3 months ago. If we look back to the data 3 months ago, on that date, there had been 230,000 deaths from COVID-19 in the US so far. Today, we're now almost up to 460,000. So in the 3 months since we've known there's been a vaccine, we've doubled the number of deaths. And of course, that number will continue to go up. So I think we've all seen the numbers, we see them every day. But I think it's useful to remind ourselves just how serious of a health crisis this has been. The all-cause mortality, so ignoring whether something's coded as a COVID death or whatever else, all-cause mortality in the US in 2020 was 117% of a normal year, which is about 450,000 deaths higher than normal. So for those of you that don't follow the health statistics, you don't normally see deviations like that. A really bad year would be 3 or 4% above normal. Here we're 17% above normal. That is the largest increase since the 1918 flu pandemic, which was much worse. We should make that clear. But we haven't seen this much of a deviation from normal in that long. So I think, first of all, and I know Phil agrees with me on this, this is a serious health crisis that we should at least take notice of. But the question is then, what should we do about it? I think, as an economist, and I'm a public finance economist, that's one hat I wear. I think when economists talk about what are the roles for government to intervene in the market and society. Economists generally, as most of you know, are very in favor of free markets and free societies with exceptions. So what are the exceptions? a pandemic, infectious disease pandemic, meets essentially all of the exceptions that economists usually talk about. So for those of you who don't know the jargon, I'll try to quickly tell you the jargon. So there are things called negative externalities, which is where people impose costs on others. Economists think there's a strong presumption for government to intervene when there are negative externalities. For example, because you can easily spread the virus from one person to another. That's a negative externality. There are positive externalities, such as with the production of the vaccine, that when someone produces that, there are benefits to society that are not captured by the person producing it. And there also just are generally what we call collective action problems. So when we try to get everyone to do a particular thing, whether it's wearing masks or social distancing or getting the vaccine, these are collective action problems, and collective action problems generally, economists think these are some of the best cases for government intervention. So, I like to say some of my best friends are anarchists, but most of us are not. Most of us think there's some role for government in society. And I would argue that a pandemic like this is actually the strongest case. So maybe if there is no case, then maybe that makes the case for anarchy stronger. But I do think that we can see that there are examples here where potentially at least government interventions could improve upon the kind of people deciding what to do on their own, which again, economists usually think that leads to good outcomes, but here's a potential exception. Now, in addition to being a public finance economist, I'm also trained in public choice economics, which, and for those of you who don't know the jargon, public choice is a subfield of public finance, you might say, which also looks at how do governments behave? What are the incentives that governments have? Are governments going to correct for these problems in the markets exactly like we would say they would on a blackboard? And public choice says, they will not necessarily always do that. So we need to think carefully about what are the incentives that governments face? What are the things that they might do? And will those actually have some unintended consequences? So I think that's, we need to kind of temper this, it seems at least in theory like a really good case for lots of government intervention versus how do governments actually intervene in practice? And then to see, taking both those things into account, what possibly can governments do to improve upon things? I also think that, especially given the seriousness of the pandemic, which isn't quite as serious as some of the models predicted back in March. I'm sure Phil will talk about that. We're not going to hit 2 million deaths, but I think even if you had told people last March that there would be 500,000 deaths, a lot of people would have still been very concerned. So I think there's a very strong urge on the part of most governments to do something, right? To do something. So a few governments, a few small states, and a few countries like Sweden have done mostly nothing. But I think that there's a strong urge to do something. So as an economist, I think about what can we give them any good advice, right? Knowing that the politicians will behave by their own set of incentives. What advice can we give them? So I think the best thing we can do if we're giving advice, and we're hoping at least that advice might be considered, is to think about what's the balance between protecting individual liberty, protecting the economy, and controlling the spread of the virus. So here's two examples. We'll probably talk about these a bit, but as where I think take a middle ground between the position Phil might take, but also there's a lot of restrictions which I think don't kind of pass this test of the benefits from the control and the restrictions and the cost of those restrictions actually being too high. So when we talk about lockdowns, and this is a term that's used to mean a lot of things, but when I say lockdowns, I mean things like general stay-at-home orders for an entire state, or just general shutdowns of what are deemed non-essential businesses. The reaction of almost every state, back in March and April was to implement these things, right, which are very broad. They affect many people in society, and they were certainly something that looked like you were doing something, but I think there are a number of problems. One is it's a very strong restriction on people's liberties, right? This is to have a restriction that heavy. I, as an economist, would want to see strong evidence before you undertake that this is going to have some large benefits. Of course, since these had never really been tried before on a large scale, there was not a whole lot of evidence these worked. So I think that's one thing. Number two, with these kind of general widespread restrictions, I think especially in a large country like the US, where the virus kind of bounced from state to state, all those really did was kind of delay a lot of infections, which would occur later. So I think, and it's a kind of restriction that's difficult to sustain for a very long time. Now, California sustained it for, I don't know what, 9 months, 10 months, but most other states abandoned it within a month, right? This is a very strong restriction. And the stay-at-home orders and the general business shutdowns. A lot of states, even places like New York and New Jersey, which were hit hard, and the political incentives there, I think, were to do a lot more. Even they had abandoned them by June. So this is something which is very difficult to sustain. And I think until there's something like a vaccine coming along or herd immunity developing, these are not really good long-term solutions. So they're high cost and not really good long-term solutions. I'm sure Phil will tell us about how the evidence now shows they don't work that much. I'm a little more open to the idea that they actually did, for a short time, reduce infections and reduce deaths. But there's such heavy restrictions, I think, that's not really something that should have been tried. And I think it's a good idea to speak out against them. I will say that, as Phil and I have had these conversations, I have not been as outspoken against these as he has. I think one reason for that is I think while these interventions are bad and have negative consequences, most of the negative consequences actually came from people voluntarily staying out of society. So people voluntarily staying home, people voluntarily still not going to restaurants. Restaurants have been open since May in Arkansas, and they're all still struggling here because people just don't want to go out. They're worried. So I think the marginal bad of these restrictions is probably, I think it's smaller than Phil would, but I think that generally these are restrictions which did very little good and caused a lot of harm. And they also, I think, shifted us away from talking about what might be some more focused interventions, right? So I think that one thing which could have been done is some more kind of targeted restrictions of places that had outbreaks. And this is actually kind of how it started, if you remember back in March of last year. A lot of school districts would be shutting down individually when they had cases kind of in that district, right? And then all of a sudden everyone got really scared and everything shut down. But I think for states that have opened up again in the fall and now in the spring for, say, their schools, what a lot of them have done is try to have some things in place like mask restrictions, social distancing, to shut them down when there is some sort of clear outbreak of a virus. So, at where I'm at UCA, University of Central Arkansas, we've been open since last fall. We've offered more distance learning if students wanted it, but otherwise we've been kind of full speed ahead. But we've been doing regular testing, quarantining of students. And when we came back from winter break, they did the kind of first week of testing before classes started, but students were back. And the test positivity rate was like through the roof. It was like, I don't remember what it was, but it was like 20% of the tests were positive. And they said, okay, what we're going to do is we're going to not open for the first week. We're going to do more testing next week. And if that rate comes down, we'll open. And the rate did come down, right? So they isolate people who were positive, and they continued testing. And that was a way to open up the schools again. And now we've been in person since then. A university is a controlled environment, and it might be difficult to do that on a large scale. But I think if we look at examples, and this question of testing, I think is a clear example of, especially if it's voluntary testing, for governments to make this widely available, there's very little restriction on liberty, but I think it has potential to do a lot of good. Now, if you get into mandatory testing, so one example of kind of mandatory testing is Slovakia. So Slovakia, at the end of October, they had kind of lockdowns in place, but they said, if you submit to testing, you will then not have to be locked down. And something like 3/4 of the adults voluntarily got tested. I might say it's not totally voluntary because it's a way to get out of this other restriction. And they were able to dramatically reduce their caseload at a time when in most of Europe, especially Eastern Europe and Central Europe, which hadn't been hit in the first wave much, we're seeing cases go up. So they did that at the end of October and had pretty good results. Then they proposed doing it again a month later. And for whatever reason, I don't understand the political dynamics of Slovakia, but people said, well, this will be a waste of resources. Hospitals have already been taxed too much doing this. So we're not going to do mass testing again. And they just kind of then proceeded as most other European countries did. And the cases went right back up. And now Slovakia is actually one of the worst per capita death rates in the world. So I think we can see, though, that testing, whether it's at a university or certain countries that try to do it in a widespread way, I think that can result in some good and with little restriction of liberty. One which has, I think, some restriction of liberty are things like mask mandates or very strong mask recommendations. And of course, almost every state in the US has done this, most countries have. This is one where, because for me as an economist, because it's a minor restriction of liberty, in fact, I would say it's not really much of one at all, but I think people personally differ on that, but certainly it's less than the lockdowns. This is one where we actually have pretty good evidence using pretty good methods to test whether actually when a mask mandate is introduced. So for example, there's a study out of Germany where the mask mandates were introduced in different districts at different times. And they use a good method called synthetic control to try to see which, whether there actually was an effect, right? As opposed to most studies would just say, well, country X implemented masks at time A, and then the cases went down. That's not a good way to study it, as Phil will tell us. But using better methods like synthetic control and differences, there have been good studies which to me say the masks do some good and may even reduce the number of cases by say 25 to 40% in some of these studies. So for a small restriction on liberty, we got pretty good evidence. That's where I as an economist would say this is something which we should think is a good intervention to support. So again, for stronger restrictions on liberty, I would say we need much better evidence. We did not have those for the lockdowns. We still don't have good evidence they're really effective. But I think we can try to have these focused interventions. Again, it gives government something to do to say, here, we're going to do this, right? And we're going to do it in a way that is a minimal restriction on liberty. What I've been most disappointed in from certain politicians is ones who have basically said, and here's where Phil and I might get in a little disagreement here. Ones that have basically said, if you want, live your life as normal, right? Wear a mask if you want it. Like this is what the governor of South Dakota said. If you want to wear a mask, wear a mask. If you don't, don't. If you want to go out, do it, right? It's your choice. I think there's a real, personal responsibility we have to take. And to me, that is just very much the wrong approach to take, that we should be, because as I started out saying, this is a very serious health crisis. We should be doing everything we can, not only in terms of policy, but in terms of our individual action to try to limit the effects of this disease. And I'm out of time, so I'll stop there, but I look forward to hearing from Phil.
Thank you very much, Jeremy Horpedahl. Now, opening statement, Phil Magness.
Thank you, everyone, for joining this evening. Thanks to Matt for organizing this, Dov for moderating, and also Jeremy for agreeing to join for this discussion. Preface this by saying that we seem to share quite a bit in common, Jeremy and I, on our respective approaches to the pandemic, although there are going to be some differences that I think teased out over the course of the conversation. I unfortunately live in one of those states that has not been very good at getting its vaccine rolled out. So that's another component of the public choice dimension that I think we're currently facing in several places around the country and also many countries around the world, and that government has not been all that great at executing on one of the things that seems most obvious that they should be doing. And as Jeremy pointed out, we're currently approaching a very horrific level of death on a very serious disease. Quite a bit, and we're almost half of it has occurred, as Jeremy noted, since the time that the vaccines were announced back in November, which in a sense strikes me as unconscionable, the way that the government has handled that. But I also want to preface my remarks by noting that anytime that there is a pandemic of this nature, the great question for a policymaker is what to do about it, and specifically whether the intervention, the benefits of the intervention itself match or exceed the costs that are imposed by undertaking an intervention. So the great question of what to do in response to a pandemic basically divides into two areas of policy. We can discuss both. The first are what epidemiologists would refer to as treatments, and that includes vaccination, but it's also things like something as simple as symptom mitigation at hospitals, which there was a learning curve early in the pandemic. We got better at treating the serious cases that were coming to the hospitals. Also things like expanding hospital capacity and rapid response. But unfortunately, the majority of the public discussion, as well as the interventions that have taken place in response to COVID-19, have fallen into a category referred to as non-pharmaceutical interventions, or NPIs for short. And this has been a dominant area of the epidemiological advice to politicians on what to do. Both treatments and NPIs raise the public choice questions about whether an intervention can actually be executed the way that it's written out on paper or the way that it's planned. I would argue that the NPIs lend themselves to a more aggressive political intervention than treatments because they fit into the politicians' need and desire to be seen as doing something, to be seen as giving out orders. It's the same type of phenomenon you encounter whenever there's like a catastrophic weather event, like a hurricane. A hurricane may be coming through a city, and the course of it's going to take is determined by factors that are often well beyond human beings' abilities to control. But you always have the mayor of the city or the governor of the state who wants to be front and center on TV, acting as if they're directing, almost centrally planning the direction of the hurricane. Pandemics, unfortunately, I think lend themselves to a very similar approach. What has that meant for COVID-19? Well, non-pharmaceutical interventions, NPIs, and this includes everything from very strict stay-at-home, shelter-in-place style lockdowns to business closures to restrictions on what hours businesses can operate to, so we even saw several examples of what was deemed an essential versus a non-essential product in the stores, what could be sold, what could be offered to the public at given points in the pandemic. Those have been the favored choices that most politicians have leaned heavily upon since the start of COVID-19. Going all the way back to the spring, we had 43 out of 50 US states impose some form of a shelter-in-place style lockdown, and they've been relaxed at very widely varying paces. So some states got rid of them within about a month or so of them being in place, but others, such as California and a few locations in the Northeast, have more or less kept the core of their lockdown policies in place for the entire duration of the pandemic, only tweaking it around the margins and then making it stricter again in the fall when the second waves emerged. So with lockdowns and closely related NPIs as the dominant policy that's emerged in the wake of the pandemic, this raises the question that anyone should be asking in terms of evaluating these policies is, do the costs and benefits match up? Do the benefits that are gained from imposing these lockdowns exceed the costs or burdens that they impose on society? And the argument that I'll make is basically no. Lockdowns have shown benefits that are weak to basically non-existent in all the places that they've been adopted. We can see this very clearly in the data, the course of the states that have had the heaviest lockdowns. Of the 10 worst states in terms of deaths per capita, I think 8 of them were lockdown states. They adopted a very heavy-handed non-pharmaceutical intervention approach that goes all the way back to the spring, but has also been recurring in some of the second and third waves of lockdowns that were imposed in the fall and winter. Oddly enough, if you looked at the epidemiology literature before COVID, a substantial theme of it was harshly critical and skeptical of the idea of even going into lockdown in the first place. So this was actually a relatively new intervention that the profession swung behind only on the eve of COVID becoming a major policy problem in the United States. We can even go back to January of 2020. I know that seems like forever ago, but this was when COVID was first starting to come on through the news cycle. We had heard word of the outbreak in Wuhan, China. China imposed a lockdown. And one of the first people they interviewed about that was Anthony Fauci. He went on CNN the day after China imposed a lockdown. And his comment was, I could never see this coming to a US city like Los Angeles or New York. And then he prefaced this comment by basically saying, we know lockdowns are a heavy-handed tool from the past, but they were something that were used in previous centuries as almost like a medieval style quarantine. And the evidence there showed that they generally were not very effective when they were imposed. 2 months later, Anthony Fauci was leading the cause to impose lockdowns in the United States. And yes, in fact, he brought them to New York City and Los Angeles and dozens of other cities around the country, ultimately 43 out of 50 states. The benefits that have been delivered by lockdowns, if you look at the just statistical depictions of them over time, and you can compare basically natural experiments that have occurred between countries and states that did not lock down and countries and states that did in fact lock down, and you can line them up when the pandemics arrives there, when it starts to peak, when it crests, when it declines, and the patterns are basically identical. Even insofar as to going, I'll go so far as to say that they're indistinguishable from basically being random. One example I'll use, if you line up the United Kingdom, which is one of the worst outbreaks in the world on a per capita basis, with Sweden, which stayed open on a per capita basis, they both follow an almost identical two-wave pattern, both in the spring and the fall, that reaches similar height, despite using completely different policies. Now, yes, I'm selecting those as case examples of two extremes, but at the same time, if you actually compile data together and look across all 50 states or look across hundreds of countries, whether they used a lockdown or not, there seem to be just recurring patterns that don't vary based on the level of restrictions that are in place. There have been some studies that have claimed otherwise, but we actually find out that these studies are based on modeling. They don't actually have a true counterfactual control to test them statistically. Yet, with all this evidence that lockdowns have failed in practice, or really not delivered anything that they've promised to do, that's certainly been the case in the United States. We may also ask the question, well, what is the counterfactual that we should judge a lockdown by? And I'd go so far as to say that the counterfactual does not need to be more successful than a lockdown state. This is why somewhere like Sweden, that had a very horrific outbreak of its own, is still worth looking at. The fact that Sweden was no worse off than other countries that employed the lockdown strategy in Northern Europe, or other states that employed the lockdown strategy in the United States, is itself its own testament that maybe the benefits of the lockdowns simply aren't there to be claimed, and yet the costs, we know, are also very severe. Some of the costs that we've encountered, a massive unemployment shock that initially broke out when there was as Jeremy mentioned, there was a behavioral response to the pandemic. The question being, what would most people do knowing that this pandemic is striking the United States? Yes, the average person decides to stay home. And this is true for the first month or so. I think most people were willing to tolerate at least a few weeks of sheltering, of reducing their activities, of abstaining from venturing out into public, because they were concerned about the uncertainties of the pandemic. But what we find is after that first month passes, after we get through about mid-April 2020, the states start to diverge not only in their policies, but also in their patterns of mobility in public. The states that open up, the states that remained open, there were 7 of them, and then over the course of the next few weeks, that basically doubled the number to the states that were opened up. There was a resurgence in mobility. It wasn't quite to pre-COVID levels, but what it turns into is over the course of the year, there's about a 30 percentage point gap between the most restricted and least restricted states in the United States in terms of people going out in public, resuming economic activity, resuming behaviors that at least have some sort of a rebound in economic activity associated with them. And what this tells us is that there is actually a clear difference between the persistence of these policies and then the states that have reopened. And that clear difference has manifested itself in both higher and lower levels of unemployment, the lower levels being associated with the more open states. We've also seen some of the other costs of lockdowns, a rapid increase in what we would refer to as deaths of despair. These are things like substance abuse deaths, deaths that come from suicide, other deferred behaviors that seem to surge at times of economic and social restrictions. And we're only starting to get some of the data in on this very clearly now for the first 3 months, I think, that have been released by the CDC after the lockdown started. And we saw a very sharp spike in opioid abuse, substance abuse deaths, similar types of problems that are very clearly associated with the policies that have been put in place. There are also long-term social costs that we see and recognize everywhere, but everything from school closures and the effects on child development and education. There are deferred non-COVID medical treatments, such as cancer screenings, that are being missed over the course of the year. This is probably going to spread out over the next decade or more in increased deaths and harms that are experienced through society as one of the side effects of having this lockdown, this heavy-handed lockdown approach. What this leads me to conclude is that the assessment of lockdowns as the primary NPI that was adopted carries with it extremely high costs, but also ambiguous benefits. And in such cases of high cost and ambiguous benefits, I would argue that the presumption should be against locking down. The presumption should be that this is not a tool that we should use, barring very clear and conclusive evidence that has not been produced yet of the fact that it works. One of the consequences of our focus on a heavy-handed, kind of centrally planned top-down approach rooted in NPIs has been a missing of the most vulnerable segments of society over the course of the lockdowns. And this is where the policy of focus protection takes center stage. One of the clear acute vulnerabilities that was noticed very early on, if you remember when COVID first arrived in the United States, the very first outbreaks were in nursing homes in Washington state. And this problem has only accelerated ever since then. According to the most recent statistics that I looked up just a few minutes ago, 37% of confirmed COVID deaths in the United States occurred in nursing homes. It's actually probably closer to about 43 or 44%. The reason being that New York State is currently undergoing a scandal of underreporting of their nursing home deaths. The reason for this is, I would argue, a misplacement of the focus in what they were trying to mitigate. If you look at the models that lockdowns were premised upon back in the spring, the main one being Imperial College of London, there's a very revealing caveat at the end of the paper that was based on, and the modelers basically admitted that they had no way of accounting for the spread of this disease or any other disease in facilities such as nursing homes, prisons, group homes, areas of society that are not covered by general spread, which is what the model predicted. Well, it turns out that tends to be a very acute vulnerability for this disease, and we now know lots of information of how that vulnerability plays out. One point of data that we just got in the last week or so, we're starting to get some comparative information, comparative statistics between countries on how they performed at protecting their nursing homes. And this is especially pronounced in Europe. Some of the worst countries in Europe, such as the UK, Sweden is not the greatest at protecting its nursing homes. It's not as bad as the UK. Spain has been very severe in its nursing home problems. All of these countries failed at what would be called a shielding test, the shield being the rate of death in the nursing home compared to the general population. And one of the issues that's occurred in countries such as Spain, the UK, to a lesser degree Sweden, is they basically failed at shielding their nursing homes, whereas other countries that are seen as success stories, Germany, Denmark, Israel, and then also South Korea stands out for a whole host of other reasons, all had effective policies that, at least in the first wave, kept the disease out of their nursing homes, even though some of these countries had lockdowns, others did not. It turns out that this is one of the bigger explanations that is used for what is actually occurring in these countries is what they did in their nursing homes. And we can see that as well in the US statistics. So I'll go ahead and wrap up my comments on this point by proposing what I think is a more suitable alternative, and that is to focus on the vulnerabilities, nursing homes being the most known of them, but by no means the only. But we can ask the question about what could have been done instead of a general society-wide, centrally planned top-down lockdown back in the spring, had we focused on known vulnerabilities such as nursing homes. Well, some of the options that I would propose as a suitable intervention would be subsidizing nursing homes, to pay their workers a premium to either reside on site or to self-limit their contacts with the outside world. This has turned out to be one of the major vulnerabilities in these types of facilities. The second thing, policy that has actually been somewhat adopted in the now going on a year since the pandemic broke out, is early on, testing was bad society-wide, but testing was also extremely poor at nursing home facilities. And it was only around August and September that the US government started to redirect some of its testing resources to entry points into nursing homes. That strikes me as a perfectly viable and very cost-effective intervention that could be made on these types of facilities that are a known vulnerability. The unfortunate problem that's emerged throughout COVID, and I argue this is also a clear display of public choice effects, including a path dependency and a bias towards heavy-handed centralized action, is that the focus on general population interventions has unfortunately meant that things like nursing homes have been neglected for large stretches of the entire pandemic. They've fallen out of the focus of policymakers and public health officials. Meanwhile, while they're pursuing these lockdown strategies that tend to be very heavy-handed. What does this mean? I would argue that the time is well past to completely reorient our strategy for dealing with this disease, including abandoning the entire concept of top-down, heavy-handed lockdown-style NPIs and more and reorienting toward a more aggressive form of interventions that focuses on acute vulnerabilities, nursing homes, people with diseases that give them comorbidities to COVID. And that includes everything from interventions could be used to subsidize like nursing homes, but also the provision of information. And I'll close on that final point. The provision of information has been one of the areas where the United States government and most governments around the world have probably suffered and failed the most. This being because of the supply of contradictory, sometimes even flip-flop style statements from public health officials. Also promises that were not delivered upon. And this goes all the way back from everything from 2 weeks to flatten the curve to more recent commentary on vaccination rates to information about whether masks should be used or should not be used. We remember all the way from the Surgeon General and Anthony Fauci on down, the US government flipped positions on that several times. Unfortunately, this has an effect of weakening public confidence in public health advice, and this coming out of our officials, the people that are supposedly guiding us through this pandemic. And when you do that, you undermine the trust in science.
Many thanks, Phil Magness.
Yep,
Your time is up.
We'll go ahead. All right. And we can go
Thank
ahead.
you. Thank you for those opening remarks. Jeremy Horpedahl, please, your remarks by way of reply, 7 minutes.
Okay, thank you. Yeah, so Phil, I know we and I think most people agree that what's happened in the past almost year in this country has had large economic and social costs, right? So then the question I think that a lot of us that don't favor, these on again, off again lockdowns and stay at home orders, what should we do, right? Because we want to either end this as soon as possible, right? And I think this is why I emphasize in my first thing I said is that, we had the vaccine 3 months ago, and then we've doubled the number of deaths since then, right? It would seem that should be the time where we say, okay, we're going to take measures which reduce in the short term the number of deaths, and we're going to do it in a way that is not restricting liberty in a major way, but people are still doing it. So, but what happened in this country in the last 3 months? And if we think about the next 3 months, right? We can Monday morning quarterback last March all we want, but let's think about the next 3 months, right? The vaccine comes out, right? We're right before the holiday season. Something like 40% of Americans all of a sudden said, yeah, we're just going to go have holiday gatherings. We're going to have Thanksgiving. We're going to have Christmas. And a third of them said, we're not even going to wear masks when we're around people that aren't in our own household. Now, I agree with you that the communication from public health experts has been very poor, to say the least, throughout the pandemic. But I think the ways in which it has been poor is actually they haven't told people things that are restrictive enough, right? First they said no masks, then they said, oh, a cloth mask is okay. And now Biden says everyone should have N95s, right? Like that should have been the message all along. Now there was shortage of supplies, of course, but I think to the extent that the communication has been bad, it's that they haven't been clear enough about here are some simple things you can do to protect yourself and others. And, you know, I think Phil and I are both libertarians. I know our whole audience is not. And we tend to think, well, people don't listen to politicians, but actually most people do. A lot of people, when a politician says something, people say, oh, okay, I'll do that. And when you have politicians saying, no, go have Thanksgiving, we can't shut down our lives. I mean, a lot of that, I think, contributed to the death we've had in the last 3 months, which were, I think, a lot of those preventable, and the deaths we're going to have over the next 3 to 6 months before we get enough people vaccinated. I think this is the time where people should say, you know, we can take reasonable restrictions. We can follow all the procedures that have been suggested. Now, I guess N95 production is up where everyone should be able to get an N95 mask. I mean, I've had them since last summer because I'm always diligently hunting for things and diligently hunting for how I can get a vaccine. But I know that's a zero-sum game, right? But now we have these things, and people, I think, can be much more careful. But there's a large part of the population in this country which is basically saying, we've had enough of this. And they've been saying this actually since last summer. We've had enough of this. We're just going to live our lives normally. And so my biggest problem with what you're suggesting in the Great Barrington Declaration is that, yes, protect the vulnerable, right? But the idea that you should do, then everyone else should just live their life as normal to build herd immunity, I think that's very irresponsible. And I think that there are things people can do outside of that. So if we're talking about places that have done well in the US, Vermont is the states that's done well in the US. Vermont has actually done a really good job at what you're saying about protecting the nursing homes. But importantly, that's not the only thing Vermont did, right? So Vermont has also had mask mandates. Vermont has had travel restrictions, which are hard to enforce, but at least they say, if you're going to come visit our state, but quarantine for 2 weeks before you come. Like they're saying that. Whereas the approach in South Dakota is, come on over and have a steak, you know, like just whatever you want. I think, you know, that's, to me, that's very responsible. And so I think we can have a limited amount of freedom, but still trying to practice safe measures. I think that's where we should be. And that's where the messaging should have been the past 3 months. I mean, when we didn't know a vaccine was coming, I agree, you know, what you should do with the lockdowns, and we can't wear masks forever, right? But now that we see the light at the end of the tunnel, it seems like people should be more safe now, whereas a lot of people seem to be saying now, it doesn't matter, right? We're almost to the end of it. People are going to die either way. People die, people won't. I think that's the wrong approach. So what I'm going to suggest is that, you know, people should be more cautious. So what does that mean, right? Be more cautious, right? We've been hearing this for months. Well, I think it's actually all the things we've been talking about, but it does mean, I think, trying to do things in a more normal way, right? You know, go to restaurants, but follow the precautions, right? Here's where I think this is a public health measure that, you know, tell people to wear masks except when they're eating, tell the servers to wear masks. And you know, the cleaning of the surfaces isn't actually that important, but, you know, so get rid of some of the security theater, focus on the things that work, and, you know, let people take some risks. But I don't think go back to living your life as normal is I think, a bad strategy. Since you brought up Sweden, I wasn't going to bring it up, but you did. So I think with Sweden, it's interesting, right? Because they've clearly done better than, say, the UK and Spain, France. Although they're catching up to France in deaths. But they have done so much worse than other Scandinavian countries, right? In fact, Finland, Norway, and Iceland's weird because it's an island, right? But Finland and Norway had the lowest deaths in Europe in COVID deaths. They are 1/10 of the level in Sweden. Denmark's about a quarter of Sweden's level. To me, the counterfactual for a place like Sweden, which those places didn't have harsh restrictions, right? What they said is they recommended people wear masks. They had much more widespread testing than Sweden. They told people that, you know, I know herd immunity was never the official strategy of Sweden, but there were lots of messages from their public health department that said things like that, you know, that's the way to overcome this. And so that's the approach we should take. I think, you know, Sweden versus the other Scandinavian countries, I think clearly shows how you can have, you know, limited restrictions, but still good public health guidance. And the Scandinavians also are, you know, they're you know, they listen to public health authorities, right? whereas maybe Americans don't as much. But I think that's something we can look at and say, there's a model for how people can behave. And we hope there's never a pandemic like this again. But if there is, I think that's kind of a middle course we can steer. So Norway, Vermont, like those models, I think to me are much better than say South Dakota or Sweden. Limited interventions, strong public messaging about taking precautions, and hopefully then we can, then we actually can get back to normal. And now that I have the vaccine, I'm very much trying to get my life back to normal. I've decided, yes, I'm now going to these conferences I've booked, and I've booked flights, and so I'm getting back to normal. And I think that we can all gradually do that, but I think everyone doing it once is probably not the best strategy. But I'll stop there.
Thank you very much. Phil Magness, 7 minutes for reply.
All right. I guess the first thing I want to talk about is the subject of masks, because those have been at the front of the public discussion since back in the spring when Fauci was saying not to use them. I do think there is a reasonable amount of evidence that masks work in certain situations, especially indoor situations, and certainly around vulnerable people. But the question would be, are they the magic bullet that they were presented as back in the late summer and throughout the fall? I mean, we even had public health officials, including now President Biden, were claiming that masks were going to save hundreds of thousands of lives if only we had a mandate, which he's attempted to enact since he took office. Unfortunately, what we've seen when we look at the evidence for masking is that there are several studies, surveys, including surveys that have attempts to control for the way that people self-report on this, have shown that at least since last July, 80% of the public of the United States is pretty consistently wearing masks most of the time when they go out into public. A lot of businesses adopted these restrictions before any of the states even considered them back in the spring. To go into a Home Depot or a Costco, you had to wear a mask through private voluntary action. Which is all fine and good. It seems to have certain effects that are associated with it that are decent for pandemic mitigation. But unfortunately, it's also had the effect of breeding kind of a false confidence that this was a silver bullet that was going to bring everything into control and get us back to normal. The evidence seems to be amounting pretty quickly that it wasn't nearly enough to do what it was promising to do. Add into that, we can look at some of the cases. I'm glad Jeremy brought up some states like Vermont. I've actually been to Vermont a couple times during the course of the pandemic and seen it on the ground. It is restrictive on paper. Although if you look at the mobility data, what people are doing in Vermont, it's actually much higher than states that we consider as comparable levels of restrictiveness, such as California and New York. In other words, people in Vermont are moving about, even if they're moving about cautiously. It's also a very small, rural, low population state, which raises the question of how comparable is that, how extractable is that to other locations in the U.S. I know South Dakota is also a similar rural, low population state that has had a worse case of COVID-19. But when you compare some of these states to areas that are more populous, areas that have large cities such as New York and California, and stack those up to places such as Georgia or Texas or Florida that have similar population centers, similar large states that either restricted very lightly or reopened really quickly. So Georgia was one of the first states to reopen. Florida had a complete reopening. Texas has been much lighter touch than either California or New York. You start to compare some of those states together, you find out that not only do they follow a similar course of seasonal peaks in the pandemic, California and New York on many metrics, including deaths per capita, are actually doing much worse under lockdowns than some of these states that are open. Sweden is an interesting case in the Scandinavian sense. You can compare it to places like Denmark and Norway and find out that, yes, they do have a higher death rate per capita. But the interesting thing there is you start to dig into the data, you find out the reasons are not so much the strategy that they chose, but rather the acute vulnerabilities and the respective failures of Sweden versus some of the other countries on acute vulnerabilities. We just got some data on this in the nursing home protection measures that Sweden took versus what Denmark took. It turns out that Sweden's nursing home shielding rate was less than half of what Denmark was able to achieve. Even though they're basically next door neighbors, they share a bridge that actually connects the two countries and has a lot of traffic between the two. But even though they're in close proximity, it turns out that Denmark did a much more effective set of policies very early on to protect its nursing homes. And that turns out to explain one of the largest differences in deaths between the two countries. Oddly enough, even though Sweden is often compared to Norway, to Finland, to Denmark, as other Scandinavian neighbors, if you look at the measures that they all took, Scandinavia in general, and I think Jeremy already acknowledged this and hinted at it, tended to be much more light touch than the rest of Europe, which asks the question, are we looking in the right place when we're attributing these to policy interventions vis-a-vis other factors that could have come into place? One of those other factors, Sweden, even though it shares borders and common cultural backgrounds as the other Scandinavian nations, it's also by far the most populous of the region. It's twice as populous as Denmark, Norway, and Finland. It also had greater mobility into and out of the country early on when the pandemic was breaking out basically undetected across Western Europe. So it may actually be a factor of a couple of different things that are completely beyond the realm of policy control that are determining the course of the pandemic. And one of the things we've seen around the world is countries that had early undetected arrival of COVID-19, no matter what they did, no matter what policies they adopted, they tended to have the same type of an initial sharp wave that tapered off in the summer and that rebounded again in the fall and winter as the disease followed a seasonal pattern. All of this raises the question to me of whether the policy interventions that we're adopting are even having an effect on the course of the pandemic at all, versus what we are imagining them to do. So when you start asking that type of a question, the cost benefit analysis really attains center stage here. If it turns out that what different states or different countries do doesn't really alter the course of the pandemic all that much in terms of their policy interventions, well, then we have to ask the question, what are the costs associated with those policies? And it turns out that a lot of the NPIs we've imposed are very severe in their costs. So if that's going to be the case of the course of the pandemic, maybe we got to change policies. Maybe we got to focus on other areas of intervention and mitigation, such as getting the vaccine out at a more rapid pace. Things that have kind of fallen by the wayside as we've been mired in this prescriptive approach that was adopted and framed back in the spring, and really politicians have unfortunately been very reluctant to abandon.
Many
With that, I
thanks
guess
for
I'll turn it over for questions.
excellent. Thank you both. Your remarks, opening and in reply, express the deep interdisciplinarity of the debate before us today. It engages science, law, culture, politics, and economics, among other fields. Our first question focuses on the last of those fields, the economics, and it's a question for Phil Magness. It has to do with a mask mandate. And the question is whether a mask mandate coupled with an appropriate public health message about other risks that remain, isn't that, the questioner asks, largely a positive sum gain? Economic growth and productivity achieved through the supply and demand of masks and increased safety and reduced risk of harm to others at no health or economic costs for a significant majority of people in the United States.
Well, the question, I guess, on the mask mandate is, what does it actually achieve? And when it was presented back in the fall and over the course of the winter as a major political talking point, it was coupled with a kind of a public messaging that assumed that mask refusal is like this widespread problem in the United States. And yet that's not at all an evidence in the data. In public spaces, at least, poll after poll after poll, going all the way back to last July, has shown that approximately 80% of Americans regularly wear masks when they go out into public. It's actually even higher than that because of the remaining 20% or so, about 15% of them are people that wear masks more or less most of the time when they go out into public. It's only like 6 or 7% that are the people that are refusing to wear masks. So if you ask that type of a question, if people are already wearing masks at extremely high rates through their own volition, what does a mask mandate achieve? Well, it creates an opportunity for enforcement. It creates an opportunity for regulators to step in and start to penalize people. And unfortunately, we know the way that state enforcement of mandates tends to operate, it falls hardest on minorities, it falls hardest on poor people, on those who are least able to defend themselves. And we've seen this anecdotally that places that have attempted to fine people or arrest people for failing to wear a mask, it's always been in like inner city locales. It's always been in communities that have been most vulnerable to that type of targeting by the state. So I guess the question was posed on what's the benefit versus what's the cost here. Well, I say the benefit is very low if almost everyone is already wearing masks on their own volition, and the costs are potentially high in other factors such as civil liberties that come with heavy-handed enforcement.
Thank you. Jeremy, would you like to reply?
Yeah, I'll just say quickly that, I think Phil's right with those surveys that when people are in public spaces, say at the grocery store, mask compliance is very high, partially because the grocery stores require it. But other surveys which look at when people are visiting people in private spaces with not members of their household, mask compliance is very low. Now, a mandate is probably not going to be very effective at getting at that, but I think the anti-mask rhetoric, I think, encourages many people not to wear the masks when they're in these private spaces. And I think that's been a really challenge over the past several months.
Now, our next question is for Jeremy Horpedahl first. To what degree do you think government policies like a mask mandate might crowd out private responses to the pandemic or internalize the externalities? Do you think that requiring certain behaviors or restricting others could create a moral hazard problem?
I think that is something that is worth considering, right? So I think as an economist, I always think about that. And we think about also, requiring people to wear masks lead them to engage in other risky behaviors. I think that, what I would say is that this is a huge collective action problem. And to the extent that there are private solutions, such as people voluntarily wearing masks, I think that only gets you so far in a collective action problem where people's individual incentive is to say, well, me wearing a mask, I'm just one more out of a million. It doesn't increase the overall mask wearing rate, and it's slightly uncomfortable, so I'm going to not wear masks. And I think, that type of, because it's a collective action problem, I think that the risks are bigger in terms of, I really don't, it's hard for me to imagine what does it crowd out. So I think that's worth considering, but I don't think that to me, that's not a major concern, but Phil might disagree.
Phil, would you like to weigh in on this?
Again, the one point I keep going back to and reiterating is that I think public health officials and the scientific community in general have really harmed themselves over the last 12 months now in terms of very mixed messaging. And unfortunately, that's a position that's going to take decades probably to repair. And it goes all the way back from an overexuberance of hubris that was displayed in the early days of the pandemic, basically with officials coming out and saying, do this and we will solve this, listen to Fauci and we will solve this. to contradictory messaging on masks. This has opened up the space for not only political figures but the public to become more mistrusting of advice that's offered to them, whether that advice is sound or not. So I think we've got a larger collective action problem here of figuring out how to repair the damage that is done and get us back to a level of trust in science that existed only 12 months ago.
Jeremy Horpedahl, at what point would it make sense, in your view, to shut down restaurants, salons, schools, youth sports, even to the point where some may end up going out of business?
Yeah, I think that that's something which, where I might be in favor of it is like temporary shutting down of schools, like I mentioned earlier, is when you have clear outbreaks, right? I think, I'm not always the one that says leave it to the local level, but I think here's a case where leaving it to the local level is good rather than, a statewide rule that restaurants should shut down, because, you could be having, an outbreak in one corner of the state and things be perfectly fine in another part of the state. So I think because, shutting down restaurants is a pretty severe restriction on liberty, and you can put in public health measures, which I think achieve a lot of what the shutdown would achieve anyway. I would say that, and because I'm not a public health expert, I don't know what the right threshold is, but if there's a certain amount of community spread, if positive test rates are over a certain level, and there are rules of thumb, 10%, 20%, I would say that's where you look to doing that, right? I would also like there to be some evidence that the places that you are shutting down are the sources of spread. I realize that when you're moving in real time with policy, you can't always have strong evidence, but I'd like there to at least be some evidence that, our hair salons really where it spreads, right? And I think with hair salons, as we've learned, you can get your hair cut with a mask on, and they lift and they cut, right? But at a restaurant, you do have to take your mask off to eat. I mean, you physically do, right? So I would say, the intervention should be limited, and there should be a good reason for them, rather than just gotta do something. So anything where you're touching people, shut it down for the whole state. I think that's an overreach, and I think it could be more focused and would have much lower cost for society.
Phil Magness, agree or disagree?
Just one of the issues that's come up with restaurant restrictions and school closures is that these policies really haven't shown themselves through in the evidence. So there have been several states that have attempted through various contact tracing mechanisms to figure out how many cases actually came out of restaurant transmission. And it's in the single digits. It's like 3 or 4%. The majority of cases are contracted at the home from people that you know. Very similar with studies of schools in other countries that have kept their schools open. Children that are in K through 12, people that are under the age of 18, are very rare as transmission vectors in society. And yet we've adopted these policies in the long term in several states, and they've both aggregated political interests behind them. We've seen this in the most pronounced ways with teacher unions resisting the effort to reopen their schools, even in defiance of pro-lockdown governors like Gavin Newsom and Andrew Cuomo have actually started to butt heads now recently with the teachers unions because you got an interest group that I guess kind of enjoys actually having a lighter workload of staying at home and is not really making its political pressures based on scientific evidence. So that's always the trick. Once you go down the route of enacting these interventions, interest groups do emerge behind them, and they can become a political obstacle to the necessary quick reversal to actually do something about it that's based on updated scientific evidence.
Both of you have relied on empirical evidence in the course of your remarks. The next question is about that. A lot of economists, the questioner asks early on, justified the lockdowns by multiplying epidemiological estimates of deaths without them with the value of a statistical life, a measure of the value of avoiding each death through regulation derived from labor market studies. That use of value of a statistical life gave massive health benefits from the lockdowns. You've both critiqued epidemiological models, but do you have any thoughts about the use of those value of a statistical life, or VSLs, derived from the analysis of smaller risks for working age people?
I have actually written a few blog posts about this recently, and I think they actually are useful, particularly because they come from economists, so they must be useful measures. Economists have been at the forefront of developing the VSL measures, but I think, I mean, I don't think we want to always put too much stock into them, right? To say that, you know, we have exactly pinpointed the exact value of a statistical life. For those of you that don't know, these are attempts, like the questioner said, to take, you know, looking at how much people will pay to avoid a certain risk, and then extrapolating what then a life year is worth. And then you can say from how many years left of someone's life is, that's, you know, if they died 10 years earlier than they were expected, here's the total loss from that, right? I mean, I think to some extent, those numbers, it's easy to make big sounding numbers by adding all those up, right? If you say they're going to be 2 million deaths and each life is worth $8 million, well, then it seems like, you know, almost the entire size of the economy. So I think that, you know, numbers like that can be misused, but I think there is value in thinking about those, especially if, like I said in my opening remarks, if we're talking about interventions which have minimal restrictions on liberty and possibly large effects on saving lives. I think that those numbers can be useful in that context.
Yeah, and I generally agree that there are valuable reasons for having estimates of the value of life. They do allow us to quantify and compare some of the claims here. I guess one of the issues that's come up in many of those studies that came out early in the pandemic is that they assumed the effectiveness of the models. They assumed the effectiveness of the policy interventions. That's turned out not to be the case. The one caveat I'd add here is what comes down to risk assessment and personal risk assessment. And I just argue, just from an intuitive basis, that the average human being knows his or her own risk better than a faraway bureaucrat. And that's often missing from the equation. That's often missing from the discussion here.
Next question is for Phil Magness, and it has to do with the nature of the liberty restriction posed by a mask mandate. Jeremy Horpedahl has suggested that liberty restriction is relatively minor. Why, the questioner asks, do you think it is a large liberty restriction?
Well, I preface that in noting I'm not opposed to wearing masks. And in fact, I wear one myself when I've gone on airplanes, when I go out into public, when I go to the grocery store, but do so under my own volition and out of respect for the companies and owners of those facilities that have asked me to do that, to go onto the property. Where I see it as a restriction takes me all the way back to the very beginning of the pandemic. Some of you may have remembered seeing this video out of Philadelphia. There was an African-American man on a city bus back in around late March that was not wearing a mask. And a mask mandate had not even been put in place. It was only a guideline that the city bus service had enacted. And what followed over the course of this video was the bus driver called in the police to report this individual for not wearing a mask. And within 5 minutes, he is being tackled and having his face slammed into the sidewalk on the ground. Now, this is not the most common form of mask enforcement, but it's something we should acknowledge as the worst case scenario of what could happen when you make something illegal, when you empower the government to enforce a mandate or a restriction on the public. You have to be prepared for the fact that someone is going to come in and use excessive force, heavy-handed policing to carry that out and enact it. So when I see cases being made for mask mandates as something that has a potential for a low liberty restriction, I just simply urge anyone to be mindful of those types of cases where excess is resorted to by the state.
Jeremy Horpedahl, would you like to reply?
I think, you know, what Phil is saying is true, that, you know, any sort of restriction on liberty can be abused, right? I think that in a society, we recognize that, and you know, a big part of living in a society with the state is we give up certain liberties to protect us generally. And so, you know, the fact that it's sometimes abused is something we should consider. But you know, the fact that there's that one example from Philadelphia 8 months ago or whatever it was, I think suggests that, you know, in many states, it just really isn't even being enforced. They maybe think, well, what's the point of a mandate that's not going to be enforced? But again, a lot of people comply with it because it's the law. I mean, we libertarians like to say, well, I'm going to ignore the law, but you know, a lot of people just comply with rules just because it's a rule, and I think that can increase compliance just from that.
Jeremy Horpedahl, next question is for you. What do you make of not a mask mandate, but a vaccine mandate, or in the alternative, a rule that would require showing that you have had a vaccine, something, these immunity passports, so-called, to be able to work or travel or engage in other kinds of activities? How serious a restriction on liberty should we consider those?
Yeah, I think that is a more serious restriction on liberty, certainly than a mask mandate, right? It's dealing with, something which, it's a new technology. People are skeptical of it. It's a personal health issue, but I do think there's still, the negative externality from people who aren't vaccinated. So, what I would say is that, when we talk about schools and things like that, there's already all kinds of vaccine requirements for schools. So I think that requiring this vaccine, once it's available enough for children to get it, even though, this is something which doesn't really kill children at any comparable rate to other things children are vaccinated for. But I think that's a reasonable thing to ask. I think for travel, especially international travel, we already have lots of vaccine requirements for international travel. As far as, can you get on a city bus without a vaccine? I mean, I think that's, that's an interesting question, but I think what you can say to people is, if you don't want to get a vaccine, then you got to follow all the other health requirements. You got to wear masks, you got to social distance, and that, that's the alternative, right? Like if you absolutely don't want to get a vaccine and we're not at herd immunity yet, then you got to follow these other rules, because those are minimal restrictions on liberty. But I think, a blanket mandate for everyone to move about in society, that's clearly a very large restriction of liberty. Even though I'm very pro-vaccine, I would be opposed to that. But I think there are ways it can be used that we have lots of precedent for doing already.
Phil Magness, would you like to add anything?
This is an area where I think the public health officials have unfortunately contributed to quite a bit of misinformation and alarm in the public. If we look at vaccine distribution right now, there are more people that want to get vaccinated than there are vaccines available in many parts of the country. There are people that would actually pay to get vaccinated if they could go do that tomorrow, but they're not able to because they don't qualify on a long bureaucratic list of regulations. I'd say solve that problem first before we even have this discussion about when and where vaccination should be compulsory. I do have concerns when you go down the route of making something compulsory simply from historical precedent. You can go all the way back to the early 20th century. Compulsory vaccination laws, even though they have very clear public health benefits and are suitable for certain circumstances, such as like enrolling your kids in school as a point of eligibility, they can and have been historically abused. The most famous instance being, if you read the Supreme Court case of Buck versus Bell, this was the eugenic sterilization case that came out of Virginia. What the Supreme Court cited as evidence to force sterilization was an existing regime of vaccination laws and cases in that favor. So we just need to be mindful of that double-edged sword. I'd say that the public health officials' approach to this should very heavily stress voluntary compliance with vaccines, stress their benefits, and do so intelligently. Another thing to consider in the vaccination debate is, do we require people who have already had COVID-19, of which maybe several tens of millions of people in the United States right now, to go back and get a vaccine afterward? I'd say no, that actually works against the concept of herd immunity being the combination of both natural and vaccine-induced immunities across the entire population, and especially now at a time of a shortage. And yet, unfortunately, some of the bureaucratic approaches seem to be one size fits all, top down orders that envision all of society being compelled to adopt a vaccine. That's something that I think public health officials should steer away from.
Our next question is to you, Phil Magness, about that scientific messaging from our public health officials that you've remarked on. A questioner asks whether, rather than bad messaging or mixed messages over the course of the pandemic, like comments that have changed from Dr. Fauci and others, is this not simply a reflection of our learning new scientific evidence over time? And as that data changes, a new message is then reflected. Is it is it fair to criticize the changing data and messaging that reflects that over time?
Well, I don't think it is, and especially in Fauci's case, he's now admitted on 2 separate occasions that he changed his messaging for political reasons, not because the data was being updated. He changed his messaging on masks because he was concerned initially that there would be a shortage of them in the hospitals. Then he changed his messaging on vaccines. This is the infamous New York Times interview where he said he was trying to coax the public to into coming to more in line with his own position. So it's like a political manipulation. It was kind of acting like telling noble lies to try and get the public health results that he thought were desirable. There are other cases where we have learned more about the course of this disease and updated our scientific information since what we knew back in like February and March. Unfortunately, I think the public health officials have been surprisingly reluctant to actually act on some of that better information. So we've discovered things like the fatality rates that are associated with the disease have a very pronounced age gradient. The older you are, the more you are at risk for it. Whereas young people, it's a very, very low risk. And that was not fully encompassed or reflected in some of these models early on in the pandemic. And actually, if you start to bring that information in, it changes what even the models would suggest. Unfortunately, we're still clinging to some of the old models. So it's a case of public health experts basically doubling down on the sunk costs of what they advised back in February, March, and April, even though we do have better data now that tells us we should probably change course.
Jeremy?
I mean, I wish the noble lies hadn't been used either. I think that was a bad strategy, and I think that's hopefully people like Fauci now realize that was not only was it bad trying to like strategically manipulate people, but it has undermined trust in public health. So I hope maybe that's one good thing that'll come out of this, is it just more straightforward, consistent guidance. Yeah, and I don't think Fauci changed his mind on masks because there was new data. I think he was lying. He thought it was a good idea, but I think that's yeah. So I agree with Phil on a lot of that.
Let's home in on another particular measure, namely testing and tracing, that requires certain measures of personal or private information from individuals. What is the right policy in your view as to testing and tracing, and what risks does it pose to invasions of liberty or privacy, given the surveillance or collection of personal information that it entails? Would either of you like to weigh in first?
I can go. So one area where I think testing is extremely valuable is the one that I mentioned early on, and that is entry into nursing homes and other facilities that have high vulnerability rates among the people that reside there. This has been something that's proven very effective in trying to keep the disease out of areas where it can become very vulnerable. Some of the risks, though, that are associated with especially the tracing regimes, just think about prior to COVID, when you got the flu or you got a cold or you just got any disease that you picked up somewhere in the public. How reliable is your memory of where you actually contracted that disease? I'd say for most people, it's probably not very reliable at all, basically, unless it's one of your own family members and someone you were living with that had the flu like a week before you did. You probably have very little idea of where specifically you got it from. So that automatically introduces an information bias into carrying out contact tracing regimes. Another way of thinking about this is if you ask someone, well, you have COVID, where did you get it? They're probably going to start speculating on the most salient events in their memory over the last week. It was at this restaurant I went to, or it was from an associate that I had, that someone had it in their family, whereas it might as well have, there's a chance that it could have been you contracted it randomly at public from someone you encountered at a gas station. So there is a bias that's automatically built into the way that this information is reported that can become dangerous. There's one instance that we know of in Australia where they have a fairly aggressive contact tracing regime in place, where there was a misreported instance of COVID being contracted from a pizza delivery man. And it turned out that he had misreported information to the government, which got filtered through the bureaucracy and manipulated, kind of like a game of telephone of one person passing bad information to the next. Each stage of the transmission of the information added more misinformation to it. And long story short is they shut down an entire state of Australia on a rapid lockdown for 3 days before realizing the error, that this wasn't even a case at all. So that's the risk that comes on the other side of a contact tracing regime. I just ask that we be mindful of that before treating it as like the next silver bullet solution that's going to come along and save us all from the next outbreak of COVID.
Yeah, I think that, the especially in a place like the United States, where once the virus is widespread, I mean, the ability at that point to control it through contact tracing, I think, is very challenging. But I think in Australia, though, I think it actually has shown. I mean, Australia has taken an approach we haven't really discussed. It's hard to replicate because, once the virus is widespread, there's not really much you can learn from Australia. Say their strategy was keeping it out, and once it's in, it's a different ball game. But I think, while the contact tracing is challenging to do and possibly involves some invasions of privacy and errors, I think that making testing as widespread and available as possible, both, states have done this to some extent. They'll set up a 1-day free testing site, don't need symptoms, just come in and do it. I think that doing a lot more of that is useful. And a lot of people actually will kind of, if they test positive, I mean, not only will they voluntarily quarantine, some people will do their own contact tracing. They'll tell their coworkers and they'll tell other people. So I think that, that can work. So I think I'm much more focused on, making the testing available. And I think that's something, again, where Phil and I will agree on this, is that, that the FDA has stood as a roadblock to getting easy testing available to all Americans, for months. I mean, these tests have been available, and the FDA has finally approved one. It's like, really, I mean, this is something where, I mean, we could have a whole conversation about FDA stuff, but vaccine, okay, I can see safety and efficacy, but the tests, I mean, as long as they seem like they're good enough, you don't need months of trials. Just let people use them. You'll get some false positives, some false negatives, but it's better than nothing. And if people want to have home tests, I think that's something that could have been done long ago. And I think on the testing and tracing, I think that would be much more important. People just want to know, am I infected? And I will voluntarily do lots of things if I know I'm infected. And there's just, I mean, especially in the early days, but even now in a lot of states, if you want to get tested, it's a whole process and it takes days to get it back. And I think that's been a clear screw up that didn't need to happen.
We've got 2 questions and 8 minutes remaining. The first is, how, in your view, we should trade the benefit of lives saved through measures that involve social distancing with non-life-saving measure costs they impose, things like cost to mental health or jobs. How is it that we should balance a life saved against costs that are less than a life but have real effects on well-being?
I'll go first. I mean, I think it's challenging. I mean, when you're talking about, balancing, these effects on these people with these others. I mean, I know economists say that's what we do, is balance the trade-offs, but I mean, some of these things are really hard to quantify, the mental health cost to someone. I think that's a really hard trade-off to make. And I'm skeptical to say that exact kind of precision in terms of trade-offs should guide us. But the other thing I would say is that the value of lives lost, I think people have this idea that, the value of an 80-year-old's life is basically nil. So, any harm to anyone else to save an 80-year-old is not worth it. But, if you would all believe this value of social life literature, the value that's placed on a 70 or 80-year-old is very similar to a 20 or 30-year-old. Now, I wouldn't say that that's exactly true and they're exactly the same, but they're in the ballpark, right? You might think, why is that? Well, people that are old will pay a lot to avoid risks. They have their grandchildren. They want to live a few more lives. They'll pay a lot of money to live those few more lives. People that are young are much more reckless. And, that doesn't mean we should abandon them either. But I think whenever you're talking about a life lost, I mean, whatever age the other person is on the other side of that trade-off, the cost to me would have to be very high to say, well, that person's 80, they were going to die soon anyway. I think the value of people's lives and how we treat the elderly is, a direct reflection of, how we think about society. And I would be, not to say we should always save a life, right? to protect someone, but if it's a minor inconvenience for someone to save an elderly life, I think of course you should do it. Even if it's, you have 6 to 12 months where you don't get to see your friends very much. To me, that's a minor inconvenience. And we'd want to look at, are suicides increasing? And Phil's talked about some of those, deaths of despair. The best data on suicides now for 2020 actually shows it's slightly below 2019. Now it's preliminary data, but this kind of massive spike in suicides that was predicted, it just never came to be. And, and we didn't know that in the front end, but I think we do know that now that the health costs to younger people are bad, but, if we can trade off for lives, I think that's not, to me, always, obviously we should ditch the lives at the end.
Thank you. Keeping in mind, we've got one more question. Phil, would you like to weigh in?
Yeah, just so briefly, I think one of the problems with juxtaposing lives versus mental health in a strict quantifiable sense is that that type of a question assumes the efficacy of these interventions, that they're actually going to save lives, and I'm not convinced of that at all, and I'm not seeing that in the data. Mental health is a very complicated issue. We don't have full suicide statistics yet, as Jeremy just mentioned, but we do have indicators. There was a CDC survey, for example, that said as high as 1 in 5 young people had contemplated suicide at some point in the last 9 months, which is an absolutely horrifying statistic to consider. Maybe they didn't pull the trigger, they didn't actually kill themselves, but that is an automatic sign of long-term mental problems that are associated with what we've inflicted here. You also have mental health issues that are manifesting themselves even among the elderly, people that have been given no choice on whether they're placed into lockdown or they're cordoned off from society, are now basically just withering away in nursing homes and having to look at their family members through a window, having no social contact. And this is almost certainly taking tolls on their quality of life, as well as what remains in that life to live in the course of their stay in the nursing home. So these are questions that all come down to personal value and subjective value that the individual themselves, I would argue, is better in a better position to judge than anyone directing this from on high through uniform one-size-fits-all policies.
One remaining question with 1 minute for each of you to respond. How would your answers change about what kind of government intervention is appropriate if the United States, instead of having this crisis of social trust, were a more socially trusting country? How would that change things for you?
Just really quickly, I think that, if we had more social trust like a Scandinavian country, I would be less in favor of mandates and more in favor of recommendations, right? I think that when you have that high level of social trust, that you can lean on the light touch much more, but you still need those. As I think we've seen with Sweden, even in a country with high social trust, you still do need at least some recommendations. But that's how I would change. Is I would be, in the United States, I think much more needing to tell people what to do and to at least have some threat of punishment if they don't.
It echoed the same as Jeremy just said. Just add on to that, we are operating in a pandemic that I think has unfortunately become extremely politicized in the past 12 months or so. It did not help that it overlaid an election with an extremely polarized set of candidates and an unpopular president as well. What does that mean for a society that has greater social trust? Well, separate and apart from the policies that are enacted, greater social trust also means that reliable and consistent communication of scientific information on something as simple as how to assess your own risk for the disease. So imagine, like, back in the spring, if we had clearly communicated that this is a disease that, if you're older than 65, you have diabetes, you have weakened immune system, you have other known comorbidities, you should take greater caution on your own behalf, irrespective of what the politicians do. That would have provided a greater calm at a time when all of society was breaking out into a frenzied alarm, and possibly even reduce some of the missteps that we had early on, whether that's missteps on information about masks, missteps on a sudden rush to close schools and colleges among younger people that were at lower risk. In some cases, even inadvertently dispersing college students across the country on a very rapid basis, possibly carrying COVID to new regions that had not been exposed yet. This is types of missteps that could have been avoided with greater trust and greater consistent scientific information. But that's a two-part game. It not only requires the public to be more trusting, it requires the scientists themselves to act responsibly and spread calm rather than alarm, and spread reliable information rather than speculation.
Thank you. On behalf of our many participants, Phil Magness, Jeremy Horpedahl, a wonderful debate. Thank you all for joining us, and look forward to seeing you all again before long.
Thanks.
Thanks for all the questions. Thanks, Matt, for setting this up. And thank you, Phil, I guess.
Yep. Thank you as well.